Well, thank you very much, Ria. Thank you very much, Reh-Fit Center, for inviting me to talk. And thanks to all the audience, virtual and otherwise, that might be listening to this. I've been here in Winnipeg since 1982. I'm a cardiologist that was trained initially in Montreal and came here trying to fool my wife into thinking we're going to be here for 1 year. And here it is, 40 plus years later, and we're still here. Reh-Fit Center has a warm place in my heart, particularly. One of the first things that I did was actually start consulting at Reh-Fit Center probably about 3 or 4 years after I got here to Winnipeg. So I spent many times meeting with staff years ago in the past and know the facility, especially prior to its renovations. What will I be talking to you tonight about? Well, here's the first title slide, heart attack. And I have an agenda, and I want to go through a few things. The first thing is I want to explain to people what exactly is a heart attack. Heart attack is a lay term. What do doctors mean by it? What is it in the mind of a doctor versus to a lay person? So I'll spend a few minutes on that. Then there's a very important and quite topical subject of, are women different from men with regards to heart attack and what differences might occur? The next thing I'm going to do is talk a little bit about the different treatments that we have to treat heart attack and speak a little bit about how effective they are. I'm going to try to tell you what to do. I have a mistake there. What to do if you think that you're having a heart attack, and then we'll leave some time for questions. It'll be, I'm sure, at least 15 minutes. So let's get right into it. What exactly is a heart attack? Well, here's a picture of a heart, and if you look, there is an area here that's outlined on this picture that says dying muscle. And a heart attack is an area of heart muscle that's dying. And if you look very carefully upstream from this artery here, there's the artery on top, upstream from the dying segment of the heart, there's a magnification going off to the side. And what it shows is this heart artery that's feeding the heart muscle. And it shows in that heart artery a buildup of cholesterol called a cholesterol plaque. And on top of that plaque, there is a blood clot. So you can think of it as this. A heart attack is a damaged heart, a dying heart, because of a sudden blockage of the artery feeding that part of the heart by a blood clot that forms on top of a cholesterol accumulation in the artery. Now, what is that cholesterol doing there in the first place? It shouldn't be accumulating there. That's one thing, if you want to ask me about later on in the question period, we can talk about. But you can think of that cholesterol accumulation as a little blister. And from time to time, these blisters, just like a blister on your finger, can break open. And once they break open, that's when the blood clot starts. And when the blood clot starts at that site, it jams up the area so that there's not enough blood flowing downstream to feed the part of the heart, and therefore that part of the heart suddenly starts to die. Doctors call that a myocardial infarction. The heart is the myocardium, and an infarction means an area of dead muscle. So that area there is the heart attack area. And it's a cholesterol plaque that a blood clot suddenly forms on to cause the blood flow to suddenly stop and cause the muscle to start dying. Now, most heart attacks, not all heart attacks, this process is what's the culprit of the problem. I'm going to talk a little bit about some other causes of heart attack unique to women, but this is the most common cause of heart attacks in both men and women. Now, I'm going to do some very basic teaching to you about how a doctor would approach this problem. So a patient will develop usually a chest pain, and they will appear usually in an emergency department or call 911. And when a person is complaining of chest pain, on the top of the list is, could this be a heart attack? Could this be a myocardial infarction due to the process I showed you on the previous slide? And the first thing that we do is we get an electrocardiogram, because that is a very accurate way to determine if heart muscle is dying. And what we look for on the electrocardiogram is we look at the little squiggles, the waves of electrocardiograms, and these have names to them. And there's one part of the squiggles called the ST segment. This ST segment is the most important sign that we have of whether there's heart muscle dying. Now, the heart muscle, when it dies, causes that ST part of the squiggles to become abnormal. And these squiggles really reflect what's happening in the artery that's lying on top of the heart muscle. Now, if the ST segments become elevated, ST elevation, which we abbreviate as STEMI, and I'm going to be using this term STEMI over and over again. That's because the artery, and here's a cross section of the artery, has totally filled up with blood clot, and you can see this brownish blood clot on an autopsy specimen. And what happens down here at the level of the heart, when the artery is totally blocked, is all of this heart muscle starts to die. Now, occasionally, or actually more frequently, the blood clot doesn't fully block the artery. And when it doesn't fully block the artery, there's still a little bit of blood going through, and there's still a little bit of nutrition of the part of the heart that's in jeopardy downstream from that narrowing. And this does not produce ST elevation when the patient has chest pain. And we call this an NSTEMI, because there is no, N stands for no, STEMI, ST elevation, whereas here there is ST elevation. In one instance, the artery is totally blocked and there's a large area of dying muscle. In the other instance, the artery is partially blocked and there is a smaller area of muscle that's starting to die. Now, how often does this happen? Well, every year in our province, there's about 700 of these large STEMIs where the heart artery is totally blocked. And every year there's about 2,100 of these smaller NSTEMIs. So that translates to about 2 a day for the STEMIs and about 6 a day for the non-STEMIs. And you can see, this is the map of Manitoba. You can see the various dots. The bigger the dot, the more STEMIs they are. We do receive some referrals from northwestern Ontario. But you can see, because most of the population is centered around Winnipeg, most of the dots and most of these STEMIs and non-STEMIs are in the Winnipeg area. Everybody that has a STEMI or a non-STEMI gets referred to St. Boniface Hospital eventually in the course of their admission, because the treatments that are done for this condition really can only be done at St. Boniface Hospital. So the STEMI, that's the one with the blood clot totally blocking the vessel and causing the squiggle, the ST elevation. There's about 2 of them a day. They're large and they're deadly. If you take one of these heart arteries and you suddenly block it, about 1 out of 10 times within the first hour, 1 out of 10 people within the first hour, their heart rhythm goes into what's called ventricular fibrillation. When that happens, because of the sudden area of dying heart, the heart can no longer pump. By fibrillating, it's all squiggling and no longer pumping and beating out the blood. And unless there's an ambulance crew at your side when this happens to you. Remember, about 1 out of 10 heart attacks do this. You will die because this is fatal. Now, probably that's the right number, and we know that because when this has been studied from different jurisdictions, ambulance reports in different countries, after a crew shows up, about 5% of people will get this fibrillation and require the CPR and the defibrillation. And we're estimating that another half of the time this happens before the patient calls 911 or before the patient gets to the hospital. So this is probably an accurate guesstimate, but it's at least 5%, we know for sure, but it's probably twice that if you take all the people that never get to medical help. Now, this happens, this fibrillation can happen in the first hour, it's often in the first half hour, and many of them are within 5 or 10 minutes of the artery blocking. Let's say you don't get this. Let's say you don't get this fibrillation. Well, then what's happening down here at the heart muscle? Well, this is little pieces of cross sections of heart, and the red is heart, and the white part is damaged heart. And if you look over time at 20 minutes, an hour, 2 hours, 3 hours, 4 hours, out to 6 hours, the white amount of damage, once the artery blocks, that amount of damage becomes larger and larger and larger. So once a heart artery blocks, there is an increasing amount for at least 6 hours of heart damage. So if you don't get the fibrillation, if you're trapped on a desert island, the amount of heart damage is small in the first few minutes, and then it gradually increases. The amount of damaged heart, the percentage of your heart that's damaged, gets bigger and bigger and bigger over at least the next 6 hours. So we say in our business, in our cardiology business, that time is muscle. The longer the artery is blocked, the more of the heart muscle will die. Now, I said I was going to talk a little bit about women. Are they different from men? Well, most commonly, women have heart attacks about 10 years after men. So if you take the average age of a heart attack in a man, if you count up all the STEMI heart attacks that a man would have, it's usually at age 62 for a man on the average. In women, it's about 10 years later. And that's probably because during the premenopausal area with the estrogen, progesterone that women have, it reduces the amount of cholesterol buildup in the heart arteries. However, after menopause, very quickly women start to catch up. So this means that these STEMIs in women tend to be at an advanced age, at an older age. Instead of on the average age 62, in women it's on the average age 72. If it happens in a younger woman, there's usually more what we call comorbidity, which means other medical problems. In other words, for a heart attack to happen in a woman in her 50s or her 60s, she's often got diabetes or high blood pressure or high cholesterol or a bad family history or a smoking, a smoker. So younger women usually, if they do get a heart attack, have more other problems. And these other problems can affect the way people describe things, because if they're overweight or if they've got aches and pains from arthritis or from diabetes, they may describe things that an otherwise healthy person of the same age might describe things. And likewise, a 62-year-old man and a 72-year-old man might describe the sensations in a different way. So part of the difference between men and women in the way they describe how they feel a heart attack may be related to different age groups and also different other medical problems going on. But even if you try to correct for all of that, women still seem to have more what we call atypical or unusual features. The typical feature is chest pain. So the women tend to have more of other types of problems. So the average younger man, most of the time, the majority of them will be complaining of chest pain. Most women will have chest pain, but compared to men, some women only have other problems instead of chest pain, like vomiting or dizziness or sweating when they have their heart attack. So it's still mostly like men, but these other things may appear and the chest pain may be relatively minor or absent in women. Maybe partially because of their age difference, partially because of their comorbidity, or just because women are different than men. There's two other issues that exist in women that don't exist in men. That typical cause of the heart attack, that cholesterol buildup and that blood clot I was talking about, that is something that men have almost always. Women have two other causes of heart attack, of blockage of the arteries. And one of them is, we'll try to explain here. This is a coronary angiogram, an X-ray of the arteries of the heart. And in a typical STEMI, where the cholesterol blister is there and there's a blood clot, one of these arteries would be suddenly blocked. And in here, take it from me, all of the arteries are wide open and there is no blockage. But this angiogram was taken from a woman that was having a heart attack. Now, normally, when the heart squeezes, and here's a picture of the heart squeezing down and trying to empty out, the heart uniformly squeezes down and tries to get rid of the blood inside its cavity. This woman that was having the heart attack on these angiogram pictures, her heart didn't squeeze down properly. There was a whole bulging area of the heart. It's supposed to look like this, but all this part of the heart was not working because this woman had a problem first described by the Japanese called Takotsubo's cardiomyopathy. And the reason they called it this was because the Takotsubo is the name of an octopus, and in Japan they used a clay pot as an octopus trap, and this clay pot reminded the Japanese cardiologist of the picture they see, this unique form of damage to the heart that happens in this condition. And it happens in about 1 out of 50 heart attacks. And it's called stress-induced cardiomyopathy or Takotsubo cardiomyopathy. As I mentioned, it was described first in Japan in 1990, and it seems to be provoked by severe stress. And it happens mostly, not exclusively, but mostly in postmenopausal females. I've seen it in premenopausal females, but I've been a cardiologist for 40 years and I can never remember seeing this in men. And this is not uncommon, about 1 out of 50 heart attacks. It's a woman and she comes in and it looks just like it mimics the regular STEMI with the blood clot and the cholesterol buildup. But it has this unique picture when you look at the way the heart is contracting. And when you do the angiogram, there's no blockage. And it's thought to be due to severe stress that can occur that can damage the heart in one of a couple of ways. Most women that have this recover. Their prognosis is good. However, it can come back. Usually there is a bad thing like a car accident or death of a spouse. Sometimes there's a good thing like winning the lottery that caused the stress that provoked this. And occasionally you just can't put your finger on any cause. So this is one thing that's different about women, mostly older women that can present just like men, but this is the cause of it. The second is shown here, and this is an X-ray of the artery of the heart. And if you can see, there's a lot of streaky white in the artery. Normally the artery should be densely black. And this is something that is called SCAD, or spontaneous coronary artery dissection. And this is much more common in younger women. about 1 out of 4 of these STEMIs, these heart attacks that occur in women under the age of 50, this is the problem. There is no cholesterol buildup. There is no blood clot. But what has happened is the arteries inside have formed little rips. And when the little rip occurs, sometimes that can block the artery and cause a lack of blood flow going down the artery. Here, the artery is open. Sometimes the artery is totally blocked. Tragically, this can also happen shortly after childbirth, or shortly before or shortly after childbirth. And I've seen one woman who just gave birth and then died from this because the artery blocked, and she damaged her heart to the point she could not be saved. It's not all that common. This is only about 1 out of 200 of all of the heart attacks we see, but it's more common in younger women. So, what are the treatments and how effective are they? Well, here is the problem. The problem is the blocked artery, and this is the usual problem with a cholesterol plaque there that ruptured and a blood clot formed. So this happens over a few minutes, possibly even a few seconds. The patient will start to complain of symptoms, which I'll talk about in a moment. And while this is happening, that you might have this fibrillation, and while this is happening, more and more of the heart downstream is dying over the course of the next few hours. And this is what you want to do. You want to convert that blocked artery to an open artery so that you can reestablish blood flow and stop that process of heart damage downstream that the patient is suffering from. So you have 2 ways you can do this. You can put some Drano in there. You can put, here's the blood flow. You can pretend this is the artery, even though it's a pretend drain. And you can see there's a blockage here, a clot. And you can give a substance. One of these substances is called TPA. There's another one called TNK. And these are so-called clot-busting drugs. And they can go in there, just like Drano, and get rid of the blood clot, and the blood will then start to flow freely again. So that's one option to treat this. You can put a clot-busting drug intravenously into the patient. The other way is by doing angioplasty and stent, and that requires putting a catheter, usually from the arm or the leg, to the heart artery, and then through the catheter going past the blockage, and then fishing a balloon with a metal mesh on it called a stent where the blocked site was, expanding that balloon, expanding the metal mesh, then deflate the balloon, pull the balloon out, leaving the so-called stent, the metal mesh there, to keep this area from collapsing down. So 2 ways you can go from here to here, one of them with Drano, the other one with a way to just disrupt and remove and smash open the narrowed artery. So these 2 approaches have pros and cons. The clot buster drug approach, there's no special equipment. To do the balloon stent treatment, you need at least $2 million X-ray room to do that. It's a very expensive setup. You also have to have highly trained staff to work in that room. Plus it uses radiation, which is another consideration. The second difference is that you can give the clot-busting drug anywhere. You can give it in Flin Flon, you can give it in the PA, you can give it in Churchill, you can give it on a nursing station at a First Nation site. However, as I mentioned before, in our entire province, there's only one place that you can do this balloon angioplasty, and that's at St. Boniface Hospital. Usually, if you give the drug, the clot-busting drug, it takes about 60 minutes to melt the clot by the time it gets into the intravenous and goes through the body and starts to work on disrupting the blood clot. The stent treatment is actually faster. From the moment the patient lies down onto the table of the X-ray room, usually takes about 20 minutes before their vessel is wide open. So this works faster. The clot-busting drug fails in about 1 out of 5 people. The balloon fails in about 1 out of 20 people, so it's much more reliable. There's less failures with a balloon stent treatment than there is with the clot-busting drug. The clot-busting drug can cause brain bleeding, which is often fatal. You can get a stroke from bleeding into your brain. That's about 1 in 100 people that get that drug. There's no risk of brain bleeding when you use the balloon stent treatment. The clot buster works best in the first hour, and then after that it becomes less and less reliable, whereas the balloon treatment will work easily up to 24 hours, just as good as in the first hour. However, you will still have proof that lives are saved, up to 12 hours. With the balloon treatment, although it has all these advantages and works better, after about a 2-hour delay from when you could have given a clot-busting drug to getting a patient to St. Boniface Hospital, there's no more advantage, because in that 2-hour delay, heart muscle is dying. So the advantage of the balloon stent treatment is time sensitive. And if the delay to get to the the balloon stent treatment X-ray room, what we call the cath lab, if the delay is more than a couple of hours, you're better off just giving the patient the clot buster drug. So when we treat people in Winnipeg, because you can easily get patients within the perimeter highway and also out to Selkirk and Steinbach and Portage La Prairie, you can get these people into the St. Boniface Hospital in less than 2 hours. How long does it take to get there? Well, this is a graph of first medical contact to opening the vessel with a stent balloon treatment. And this is measured in minutes. So what's the time from when an ambulance attendant walks up to you at your house when you call 911 for a heart attack versus walking in the front door of St. Boniface Hospital emergency room versus walking into another emergency room like the Grace or Health Science Center? Remember, the treatment for the X-ray treatment is available at Boniface. You don't have to take an ambulance transfer from, let's say, the Grace to St. Boniface. So that's why I broke it down this way. So in one instance, you have an ambulance showing up to your door, and from that ambulance arriving to you having your artery opened at St. Boniface Hospital, it's about 68 minutes. If you go to the emergency room of St. Boniface Hospital with a heart attack and you start the clock ticking from entering the front door to getting the artery opened, it's longer. It's about half an hour longer, because things take longer when you go to the emergency room versus getting picked up by an ambulance and going straight to the X-ray room to get the treatment done. And finally, if you go to a non-St. Boniface hospital like the Grace or Health Science Center, it's almost a full hour longer to get your artery opened. So you can see that if time is muscle, the best way to get your artery opened and save muscle is to get the ambulance to bring you straight to the St. Boniface X-ray department than to go to an emergency room. Even in St. Boniface, it almost adds half an hour extra time delay. So what do you do if you're having a heart attack? Well, you have to know the symptoms. Anybody that is younger than 30 with chest pain, if they're having a STEMI, that's how they show up with chest pain. Chest pain predominance in younger people. And in all men, about 80% of all men, regardless of their age, chest pain will be the reason that they show up saying, I have a problem. In women, it's less, it's about 75%. And then as you get older, other symptoms besides chest pain start to become the predominant or possible complaint. For example, sweating or shortness of breath or upper body discomfort or weakness or lightheadedness. And in the elderly people, often they just show up with nausea or abdominal pain. So chest pain is the most common problem that you'll have if you have a heart attack, regardless of your age. But as you get older or in female sex, chest pain might become less of a problem, and the biggest complaint may be sweating or shortness of breath or abdominal pain, depending on the age. So what to do when you're having this chest pain? Well, remember, I showed you these two slides. I'm going to show you one of them. Remember, when you're clutching your chest at home, deciding what to do, well, you have a choice to make between grabbing the telephone and calling 911 or getting in your car and driving to St. Boniface or the Grace or some other place. But if you do make the wrong choice and get in your car, this might happen to you on the drive to the hospital and you will die. There's one patient that I was treating where this happened. He was having a heart attack. He chose to drive himself to the car, and by some miracle, he had this ventricular fibrillation and crashed into one of the ambulance stations in the city. And so when they came out to see what had happened, they were able to do this and get his heart started. But if he would have crashed into a 7-Eleven, or to a McDonald's, he would be dead. He would never have survived. So by calling 911, you get the ambulance crew with a defibrillator on the scene to reverse this if it happens to you. And then finally, I told you that the arteries are open the fastest when you dial 911. The shortest times to open the artery are in the patients that dialed 911 compared to patients that came to the emergency of St. Boniface or came to the emergency room of other hospitals in the city. So when you have chest pain, when you think you're having a heart attack, these are the people you want at your side. You do not want to be taking yourself or your loved one in a private vehicle to an emergency room. We are going to start a campaign shortly, and we're going to have this particular decal put on all the ambulances in the province. And this decal is self-explanatory. It says heart attack. If you have sweating or chest pain or shortness of breath, dial 911, don't drive. So we're calling this campaign DDD, dial, don't drive. So I spoke for 31 minutes. That was my plan. And now I can open up the floor to any questions that might be coming to your mind.
Thanks, Dr. Ducas. That was great. Covered lots of information. So if anybody has any questions that maybe came up earlier, again, you can use the chat box and then we can share them with everybody that's on the call or the talk tonight. I guess I had one, and maybe it's obvious, I'm not sure. Is it ever a possibility that depending on where someone was, they would get the clot buster drug and still get an angio, or is it kind of one or the other?
Well, that's a great question. Okay, as I showed you the picture of our province with all the red dots there, there's a lot of places in our province where the red dots were more than a couple of hours away. And what we do for the places that cannot get to our cath lab within 100 minutes, we say 100 minutes because it takes us an extra 20 minutes by the time they get in the door and sign the consent and get draped and get the artery open. And I mentioned that the benefits is in the first 2 hours, so that's 120 minutes. So if our transport times are predicted to be longer than 120 minutes. So let's say you show up at Pinawa or you show up at Flin Flon. Well, they're not going to get to St. Boniface Hospital in less than 100 minutes. So they have to get the clot busting drug. And to answer your question, we use a drip and ship philosophy or approach. Anybody that gets the clot busting drug dripped into them immediately are put into an ambulance transport, an air ambulance, a life flight, STARS, as soon as possible to be sent to St. Boniface Hospital. And the reason we have this immediate transfer is about 1 out of 5 people, the clot buster drug does not work. And we want all of the patients, whether they're in Flin Flon or whether they're in Norway House First Nation or wherever they are, we want them to be on the way to St. Boniface if they're one of those patients where the drug doesn't work, so that they can get the balloon stent treatment.
Nice. Somebody was asking, I guess it was one of the first slide, why does cholesterol accumulate in the arteries of the heart? And what can people do to prevent or minimize this?
Yeah, well, first of all, surprisingly, this starts in your teens. When autopsies were done in soldiers in the Korean War, or when later on in the 1970s, autopsies done in motor vehicle accidents of people in their 20s, they 3 out of 4 of them have the beginning of these cholesterol blisters starting in their arteries. It's extremely common in our population. And it usually takes up until age 62 for these things to gradually get to the point where these cholesterol accumulations will start to pop and the so-called STEMI, the heart attack, occurs. Now, why does it happen? It happens because there's cholesterol that's carried in your blood, and that's part and parcel of the way your body works. And gradually, this can start to go through the lining of the artery and start to accumulate, kind of like rust in the pipes. And there's a few things that increase that accumulation so that these blisters will occur earlier and will pop earlier and cause heart attacks in younger people. These few things are things that stress the lining of the arteries. For example, high blood pressure. High blood pressure is causing a hydraulic stress, a pounding on the lining of the arteries. And that is something that will increase the cholesterol buildup so that, it'll start to happen more rapidly. Another is just the amount of cholesterol. There's some people, because of bad genetics, have very high levels of cholesterol concentrated in their blood. Even with normal or low levels, if the lining is weakened by things such as high blood pressure or cigarette smoke or diabetes, then the cholesterol will start to accumulate more quickly. So what do you do to try to prevent this from happening? Well, there's a few common sense things. First of all, you want to make sure that you have a healthy lifestyle and that you go to a doctor to make sure your blood pressure is not high, that you go to a doctor to make sure that the cholesterol in your concentration in your bloodstream is not high. If you are overweight, you increase the chance of having both high blood pressure and diabetes. So you want to have a proper ideal body weight. You want to be exercising regularly. And there are very good, safe drugs that are been now all generic. They've been around for years and years that can very nicely lower cholesterol and prevent heart attacks from happening. So it happens because there's just an accumulation with age. It starts in your teens. It takes many, many years. There's certain things that increase the accumulation, and there's ways to try to reduce that accumulation. If you've already had a heart attack, it's not too late. The cholesterol drugs, the so-called statin drugs, are extremely effective, and we even have now more powerful drugs also than the statin drugs. And we know by looking at patients that have had repeat angiograms done, looking for the amount of cholesterol buildup, that with drugs you can actually reduce buildup as long as you reduce the cholesterol concentration in your blood by at least 50%.
Good. Thanks, Dr. Ducas. There's a couple other questions and comments. So Todd was kind of saying, I guess it sounds like a lot if you're not living in Winnipeg, it's a bit of a disadvantage if you were to present with a heart attack. Do you have any comments on that? And I guess the follow-up is, how does the province decide upon using stars to pick up the patient or versus a road ambulance? Is it a certain distance or is it a severity of condition, I guess?
Okay. Well, you have to, understand reality. Not everybody's going to live in Winnipeg. We know that up front. And to address that, to make sure that we have the best treatments available no matter where you are with a heart attack in the province, we have an association in the province called the ACS network, which ACS stands for Acute Coronary Syndrome. That's really what a heart attack is. It's an acute coronary syndrome network. And we have a group of people, I'm the medical lead on this. We have healthcare providers across the province. We have certain standards of care that we've developed to educate all healthcare providers across the province. We have algorithms to make sure that everybody in the province is getting the same kind of treatment and make sure that it's being given in an optimal fashion. And we're also doing statistics all the time and reporting back. So yes, you're right. Not everybody is going to have the same treatment, but we're stuck with that. We can't force everybody to live in Winnipeg. So to address that, we have the ACS network, and the ACS network its goal is to ensure that there are the best outcomes no matter where you are. We've also partnered with the First Nations reserves. We've made sure that the First Nations reserves now have TNK, the clot busting drug, which is something they didn't have a few years ago. We have the pathways in place to make sure that all of the patients are dripped and shipped. They're always sent to St. Boniface Hospital after they get the clot busting drug. With regards to the question about, how is the decision made? In Brandon, there is a central control called the MTCC, which I don't remember off the top of my head what the letters stand for, but all 911 calls outside of Winnipeg, doesn't matter whether you're in Flin Flon or the PAR or Selkirk, all 911 calls go to this MTCC in Brandon. And they have a group of people there, and they make the decision to send the nearest ambulance. If a hospital calls to transport a patient, depending on where the patient is, depending on the weather, they know how to decide what the best way to transport the patient, be it ground ambulance or STARS or a fixed wing aircraft. So we have those bases where we have those bases covered. We are acutely aware of inequities in health, inequities in our First Nations people, inequities in patients that live outside of Winnipeg, and we are working hard to try to limit these inequities and to make sure that the best outcomes are available for all Manitoba citizens, no matter where they live.
Great. Two more questions. One is referring to chewing a baby aspirin, I guess, and if it's having any real benefit. And then there's a couple questions about statins, and if you're taking a statin for high blood pressure, does it reduce or lower your risk of having a myocardial infarction?
Okay, aspirin. Health Canada officially was approached by the Bayer company, which makes aspirin, one of the many manufacturers of aspirin. And they set up a committee to review all of the scientific research on chewing or taking an aspirin in the first hour after the heart attack. And I was one of the members of that committee. And we reviewed all of the scientific literature, all of the research that has been done, and it's very clear that aspirin reduces your chance of dying. It doesn't reduce it to zero, but it'll knock off a few percentage points of people if they chew aspirin from dying compared to if they don't chew an aspirin when they have a heart attack. So this was formally reviewed by a panel. I was a member of that panel. We reviewed all the medical literature, and Health Canada formally approved Bayer to advertise chewing aspirin and calling 911. And you'll see those ads on the media, take 2 aspirin, chew 2 aspirin and call 911. That's because there's scientific proof that's worthwhile. With regards to statin drugs do not lower blood pressure. However, people that have high blood pressure have a tendency to build up cholesterol in their arteries. And we know that people that have high blood pressure that take a statin drug have less heart attacks than people that have high blood pressure and don't take a statin drug. Likewise, we know people that have diabetes who take a statin drug compared to people that have diabetes that don't take a statin drug. People that take the statin drug have less heart attacks. So this is something that you have to discuss with your doctor, and your doctor will know what your cholesterol level is, knowing your age, knowing your blood pressure, whether you smoke or not. We use all of these factors to determine who should be on a statin drug to reduce their future chance of heart attacks. Remember, it starts in your teens, but it takes years and years for this buildup of cholesterol to cause a heart attack.
Great. Thanks, Dr. Ducas. We are at 7:45, so that's good timing. I don't see any other new questions in. I have to wholeheartedly thank you for the opportunity to listen to you. You are a wealth of knowledge and experience, and it's amazing the stories I'm sure that you can relate, and all the different committees that you've been on, and the impact that you're having in our city and our province is a huge thank you. So again, thank you so much for taking the time to share with us the information and to be part of our Fit Talk series. I want to wish everybody a great evening. I want to encourage you to come join me on Thursday of this week. We are going to have Dr. George Keokis, who I'm sure Dr. Ducas knows. He's going to talk about how stress affects your health and what you can do about it. And it's supposed to rain on Thursday, so you have no excuse but to come and join me, because there's nothing going on outside. It's going to be raining. So I look forward to seeing everybody tonight. Huge thanks again to you, Dr. Ducas. Lovely to see everybody. Thanks for coming out. And we will see you on Thursday. Thank you.
Okay. Bye-bye.
Bye.